Could I ask you to picture this? You hop onto your bicycle with some mates on a Sunday morning ride. After a tough climb, you're flying downhill at 80 kilometers an hour. You're round a gentle bend, and suddenly there's a hairpin corner right in front of you. You slide off, massive crash. You're picked up by an ambulance, but the first question the responders ask isn't about your injuries. It's, does he have health insurance? Before heading to hospital, they detour past your parked car to retrieve your proof of cover. Before any operation, approval is sought. Any funding gaps must be closed. The treatment is world-class and immediate, but only if you can afford it. Fast forward a few years, you're in a different country, on that same fixed-up bicycle, training for a long-distance triathlon on a flat farm road. A dog bursts through a hole in a fence and knocks you off. Once again, an ambulance is called, you're taken to hospital. Surgery is semi-urgent, but demand is high, with ski injuries taking up all available slots. No one asks about payment, but the delay in treatment risks permanent injury. These are two personal experiences that I've had, living in different countries under two very different health funding systems. One, highly privatized, offers rapid access to top-tier medical treatment, if you have the money. And the other, universally accessible, equitable, but constrained by supply, where waiting lists can really impact on patient outcomes. So here in New Zealand, we face some similar and related challenges. We've got a public health system under pressure with supply issues. We've got a private system where rising costs and age-based premiums are making coverage increasingly unaffordable, especially for those that need it most, that they're aged. So welcome, everyone. My name is Alex Kühnast, and I'll be facilitating this session, which is called, Is Systemizing Integrated Public-Private Health Funding the Answer? So I'm joined by three fantastic panelists who bring diverse perspectives to this important conversation. We have Claudia Wyss, CEO of Canopy Healthcare. We've got Dr. Amy Chan, Associate Professor of Pharmacy at the University of Auckland. And we have Professor the Honourable Greg Hunt, former Minister for Health in the Australian Parliament. So together, we will be exploring how we might better combine resources and streamline processes to reduce pressure on both systems and improve outcomes for all. If I could remind you to please submit any questions on the online link. Make sure that you select Great Room 4, otherwise those questions will not be coming through to this room. All right, so let's get started. I'll now hand over to our panelists. I'll start with you, Dr. Amy Chan. If you could maybe introduce yourself briefly, and then each of you, please give us your thoughts on that central question. So how do we better align public and private funding to create a more efficient, equitable, and sustainable health system?
Thank you very much, Alex. So lovely to meet you all. As Alex kindly introduced myself, my name is Amy. I'm the Associate Professor at the School of Pharmacy, also incoming Head of School, also Clinical Director for Asthma New Zealand. So I have seen both public and private health. I've also worked at Health New Zealand for a number of years, but also work also privately as well with Asthma New Zealand. So there are definitely strengths of both systems, which I'm really pleased to see it as a topic of debate. But before we get into that, I will hand over to my co-panelists to introduce themselves. So, Claudia.
Thank you, Amy. So, kia ora koutou katoa. Just like Amy, I've also done lots of dibbles and dabbles across the private and public sector. So, I was training in surgery, ended up running and starting the private hospital division of Middlemore Hospital, ended up doing my MBA in the States and then working for McKinsey to try to help redesign healthcare systems because this is a global challenge. And while working with the healthcare systems in the US, the UK, and across New Zealand, I've spent my time on the pharma side, biotech side, hospital side, and of course, now I'm Chief Executive of the Canopy Healthcare Group. We are facing significant challenges. So the question that you're asking us today, Alex, unfortunately is a question that I've seen reoccurring for 26 years. And the biggest challenge we've got is no one's solved it yet. We see areas of examples where this is working and where there are some more sustainable solutions, but we're still seeing significant tensions. And fundamentally, there is a mismatch, I think, in incentives. And as a result of the mismatch in incentives, we do run a little bit of a risk and mismatch of trust. And so therefore, to help solve for this, there's an opportunity, I believe, to do this all better together. But for that, we need to have both the regulatory frameworks that allow for it, and importantly, the time horizons, shared data, and shared governance to help it work. And none of those things are easy, particularly in a politically fraught environment.
Great. Well, kia ora to all of you. So, Greg Hunt, obviously from across the ditch, as someone said to me, from the Western Island. And in a previous life, I was responsible for health in Australia, in the Australian Parliament. I'd spent 2 decades in the Parliament, and I was in the ministerial role for 6 years and in Cabinet for 9. But in particular, I was in health for those 6 years, and that included COVID. And now a professor in health systems and medical innovation, University of Melbourne, University College London, chairing Monash University's Mental Health Institute, and then doing private work in medical and biotech, private equity and legal, in particular with Expedite here in New Zealand, which is what sort of brought me out. But my observation is what Claudia says is correct. You know, every health system in the world is under pressure. So I think that's a really important thing to understand. The US has 17% of its GDP which is spent on health, with inferior outcomes to New Zealand and Australia, which have respectively about 10%. The UK doesn't have outcomes that are as good as Australia or New Zealand, even though they have an outstanding system. And I asked my chief medical officer, why is this? And he said, waiting lists, and therefore later diagnoses, and therefore later treatment. And something treated at stage 3 is vastly more challenging than something treated at stage 2 or stage 1. And so against that background, to put all of this into perspective, when you look at the COVID years, the Lancet Journal last year published a global burden of disease study looking at 204 jurisdictions. Average life expectancy from the start of 2019 to the end of 2021 dropped globally by 1.6 years. In the United States, it dropped by 2. In Australia, it went up by 0.2, and in New Zealand, it went up. These are 2 of the only countries in the world where that happened. So the foundation is much stronger, but the question is how to maintain and continue to strengthen that. And probably the thesis, which certainly from my perspective, Alex, is that a hybrid model, slightly different in New Zealand, slightly different in Australia, but a hybrid model of public and private is indispensable for innovation, for the contribution of private resources, but also to attract and retain the global talent. But going forwards, I think that the 2 countries can create something of a single zone in clinical trials, potentially in health insurance, and in a number of other areas, which will allow interoperability, but also to be more of a destination for global talent, patients, capital, clinical trials and innovation.
Maybe you can elaborate on that a little bit more. What do you think are the most critical features that we would need to have in that hybrid model in New Zealand?
Yeah, so one difference in either direction between Australia and New Zealand, we have a higher rate of private health insurance. It's about 55%. And the real driver behind that is that there are carrots and sticks within the Australian system that are very significant. We have a tax penalty or surcharge of 1, 1.25%, 1.5% for people over about 97,000 in income, and it increases up to that 1.5% rate if you do not have private health insurance. Hence, it's a deadweight cost if people don't have it. And then we have, commensurately in the other direction, a rebate on private health insurance, about 7%, 14%, 21% for lower income earners. And that has a surprising impact, coupled with what's called community rating, which means you pay exactly the same for the same tier of health coverage, no matter what your health condition or age is. And those two things, the carrots and sticks and the community rating, might be something that could be considered here. And then on the other side, what you have is a transition between primary care and emergency departments with your triage centres, which is largely lacking in Australia. We did some pioneering things, the current government's trying some things, but it's a worthwhile innovation. So those would be an exchange in each direction.
Yeah. Certainly, I think some carrots and sticks would be useful. Claudia, you mentioned inefficiencies. What are the biggest inefficiencies that you see in the current public-private?
So that's very interesting, and it's a very big question. So I think the first inefficiency is around planning, timing, horizons. So what I mean by that is, for example, the public sector works on understandably quite short horizons. That's driven both by legislation, driven by politics, and public expectations. And those short time horizons create a planning inefficiency. And what that means is that it's very difficult to forecast demand. We might know demand, but then it's quite difficult to supply for that demand. And so, of course, if we can't supply the workforce in the public sector, if we can't supply the money to open beds, deliver the services, then those patients will either experience an increase in wait list, or if they are and happen to be insured, they would then go to their insurance provider. So we have seen, as you would probably be very familiar with, a significant increase in demand of private insurance use over the last few years. And that's created financial pressure for our insurers. And that financial pressure for insurers is probably not uncommon in a typical insurance cycle, but this is a lot of catch-up from COVID. And as a result, the pressures are even greater. So then what happens? Those insurers constrain money, or they put up the premiums. That drives more people outside of the insurance market back into the public sector. And it makes the problem worse. And people who need treatments, and we, for example, are the largest private oncology provider in New Zealand. We do chemotherapy services, that's just one of them. But of that service, we are facing challenges in that demand not being able to be met simply because of insurance limitations, but a significant increase in demand. And so that planning cycle, the funding cycle, the perhaps the misaligned actuarial analysis of what's coming on the horizon and how does the sector think about this together makes it very difficult to make investments, to make workforce plans, and therefore to do that at a much better price. If we as a provider get a contract, we might get a contract for 3 months in some instances. And that is for services that require multi-million-dollar investments. And it's difficult to forecast if we can make those investments or to have that certainty that those investments make sense if you don't have a big enough portfolio to balance for that, or if you don't have other ways of reducing that risk. And so that's one of the really, really big inefficiencies, because we can't easily plan ahead. And I think that probably affects everyone. And that's just one of many.
Any potential solutions to that? Amy, perhaps duplication? Do you foresee any duplication in the current system, and what can we do to alleviate that?
Yeah, I do echo a lot of what Claudia has said around the inefficiencies and the inability to plan and forecast of budgets. But I think the other thing is that Claudia mentioned is around, being able to look at shared goals between the health sectors, between both the public and the private. And without that line of sight to know what the deliverables are, there are so many opportunities which could help curb some of those inefficiencies. And I know Claudia also mentioned the word data at the moment, which lots of sensitive connotations, but data is fundamentally so important for both that planning cycle and the forecasting. And at the moment, we know that private providers hold so much data about their own patients. And we know in terms of accessing pharmaceuticals, there's a lot of, pharmaceutical sales data that is captured as well within the private sector. But fundamentally, a lot of that data could also inform public health planning, but that data isn't being shared. So I think some of those inefficiencies and duplication innovation could really be curbed if we had better oversight and sharing of data between both the public and the private sector. And if we could work together to think of what the shared goals and the deliverables are, then we can draw on, as Greg said, what are the strengths of the private sector. So the private sector benefit from the benefits that Alex mentioned in terms of agility, being able to have access to technology and innovation and top-of-line healthcare services and infrastructure. But then the public health sector obviously benefit from volume. And in New Zealand, we know around 80% of the health services are still tax-based and funded. So being able to think about the pure volume and access from the public health sector, what can we do in terms of amplifying the benefits of that private sector to reduce some of those inefficiencies. And there's so many learnings, I think, that the public health sector could draw on from the private sector that we're fundamentally not accessing. So all this knowledge is captured in the private sector, but I think the public sector could definitely refer and learn from those learnings to reduce some of those inefficiencies.
So to take, I think, the ideas and challenges which have been set out from Claudia and Amy, it may be that you could look towards a public-private partnership across New Zealand. Understanding the integrity of the public health systems is fundamental in both countries, but I could imagine three things. One, I mentioned some ideas in relation to private health insurance, the carrots, the sticks, the community rating. The second thing is absolutely the data sharing, subject to consent and anonymity. Those are the golden rules. But, for example, an Australian firm has a US genealogy provider, so they had DNA samples. They went out to their patient list and asked for consent. They got 2/3 to say yes to provide their data to US crime-fighting organisations such as the FBI. And then they received a significant return on that. The FBI solved the Golden State Killer case with that DNA. And I would not have expected in the US for crime-fighting purposes a 2/3 consent rate, but they did. You could imagine a Southern Cross or others saying, well, we'll give you access not to money, but to additional benefits such as early and innovative medicines that might not be covered under your policy. So you can, that's the data. And then the third thing is greater use of public and private. So exactly Claudia's point about this idea that long-term offtake agreements. So it could be, for 1,000 MRIs, for 1,000 radiation oncology procedures, for 500 hips and 500 knees to be done over a period of time. So it's not just short-term contracting and agreements. We have in Queensland what's called Surgery Connect, which is probably the best example in Australia, where they will do longer-term offtake agreements to reduce public waiting lists by having these procedures done for public patients in private. Helps the private system, reduces the waiting list in the public system, but it's the long-term agreements which are necessary.
There's another interesting dynamic. So I used to be the deputy chair of Pharmac, and there's another interesting dynamic that we also see in the New Zealand sector, which is, of course, fragmentation. So we've got ACC, which has a different funding model. We've got Ministry of Health Te Whatu Ora funding, and that's gone through a lot of changes over the last few years. So that's starting to look like it's settling again. And then we have Pharmac funding models, and all of them are also interlinked, and it has an effect on the private sector as well. So if I give you an example of some of the Pharmac aspects that they're currently looking at, which is if you, for example, get Pharmac-funded medicines, those Pharmac-funded medicines for cancer are not eligible if you're getting your treatment for cancer in the private setting. And so what that does is that people go to using their health insurance, they might use the private setting, and of course health insurers are very deeply worried about the cost of cancer. They will hit a ceiling, and then they'll go back into the public sector. But likewise, some drugs are funded by Pharmac and some are not funded by Pharmac, so that changes the dynamic again. And that adds another layer of complexity. And so one of the areas that we've been keen to explore is how do you solve for that funding? Because if a person could get pharmac-funded medicines and they could still receive their treatment for those medicines outside the public setting, it would free up capacity in the public setting and thereby not push other people back to the wait lists. Now, of course, it sounds very self-interested right now because I'm working in a cancer area, but we do see these tensions are created in the system, not even through any fault, but simply because there are different rules that apply to each of those organisations. So getting an alignment of rules and looking at where the current legislative frameworks don't align, where there are mismatches, and importantly then where there might be mismatches for health insurance. I think that's often where it might be needing to start off.
Yeah, I think that's a good point. I mean, certainly as an actuary, we love data and often are quite frustrated at the inability to get an overall understanding of the overall demand and treatment protocols running from end to end. So obviously where there's handovers between public, private, ACC, then private, etc., there's most likely a fair bit of inefficiency. Amy, in terms of that regulation that Claudia is mentioning now, what is the optimal level of regulation? Obviously, we don't want to go to an overly regulated environment. What are your thoughts on that?
It's an interesting, tricky question, isn't it, around the optimum? I mean, right touch regulation is the one that achieves the best outcomes for our patients, obviously, in the health delivery. But there is a degree of tensions between the different stakeholders, which really makes the right answer a difficult one, because we think of the stakeholders in the health system. We have patients as ourselves, and so obviously they want faster access to treatment and access to the best treatments possible. But the tensions, obviously, from a finance point of view, is that it may not possibly be the best and most cost-effective measure. And then when it comes to regulation, you say who's in charge of the regulation and who's putting in the rules, as you said. And so I think when we think about right touch regulation, there's a couple of points I think to consider. Firstly, I think is who are the players and what are the key deliverables that we want. And when it comes to regulation from a government point of view, what does the government, how much can the government actually influence the private sector? And I think at the moment that's where some of the sticking points are. If we look at the UK, for example, the UK have the National Health Service, NHS, and the government really regulates most of the NHS. Some of the benefits of that health system is that you can see all the touch points, and they regulate all the touch points, including from the private community pharmacies and all access to medications. That's all inputting into one big boiling pot, and you can have access to all those data points. So from that point of view, it's very beneficial. The downside, as Greg has alluded to, is doesn't always produce efficiencies, nor has it produced health outcomes in the UK, and the UK health outcomes are not better than New Zealand, and that really comes down to the long wait lists that patients in the UK see. So when it comes to then the regulation point of view in New Zealand, then if we can get that balance between public and private regulation, what can we do in terms of being able to have still government oversight from some of the private input? Is there some way that the public and private sector can look to have an optimal level of partnership and some data sharing, and to a level that allows sufficient planning? So in New Zealand, one of the most difficult parts is the public health money that is invested. We can only see from a data point of view all the hospitalizations, for example, but all the we can only see the touch points with the public health service as outcomes. What we can't see, which is very much a blind spot for us, and definitely from an academic point of view, from a research perspective and a planning perspective, we simply can't see what is happening in the private sector. We can't see, for example, the use of privately funded medications. We can't see in terms of like who's using specialists, and we definitely can't see like how many of those specialist touch points have gone wrong, and then they have then ended up costing the health system even more. For example, when private surgeries go wrong and they go back to the public health service. So there needs to be some sort of regulation to allow us to both see that data, but also to have that right touch regulation so that the private health system can also input into the public health sector.
Yeah, I think those are some great points. In terms of what doesn't work, Greg, you've expressed carrots and sticks, etc. What doesn't work in terms of what you've seen internationally?
Yeah, sure. So, I mean, if I had to choose between the US, the UK or the New Zealand and Australian model, I think the US has soaring peaks, but massive valleys. I mean, what you described, for your bike accident, whether that was South Africa or the US, it's a proxy for the US, and so many people miss out. The UK, they have amazing clinicians and medical facilities, but massive waiting lists. I have a position at University College London, and the professors there, were saying we can't get in, as people who know the system. I met an Oxford professor who slashed his hand in a gardening incident and wasn't sick enough to get into an emergency department and couldn't get into a GP, so stitched himself up. And so there are enormous challenges. So the hybrid model, I think, is an excellent model for both countries. And every health system has to start from where it is. You can't imagine into being something, that doesn't fit with the foundation. So, for New Zealand, what strikes me is you have a slightly higher public sector, about 80% of your healthcare. It's 2/3, 1/3 in Australia, public-private. But interestingly, I think our public and our private are slightly more integrated. And in part because of the health insurance, in part because our Pharmac equivalent, our pharmaceutical benefits scheme, just applies wherever the treatment occurs. It's blind to the treatment. It depends upon, is the medicine on the public list, in which case it's available to everybody with that condition who's prescribed, and has the patient qualified for that with a physician that's signed off on it. So I think that one observation may be, I am beginning to think an umbrella structure of public-private partnership to reduce waiting lists in public and to give people more choice. But if that does attract doctors from around the world, one of the things we're very fortunate at is to bring nurses, doctors, allied health workers from around the world to both our systems, but they enjoy working in that hybrid model. And if it can be easier, and if there's data sharing, a proper consented anonymised data sharing agreement, you'll get better outcomes. So that partnership, private health insurance levers, data sharing, and then the public patients in privates to reduce waiting lists. That's the simple explanation for the minister or the prime minister. Reducing waiting lists could give you more leverage.
So who takes the first step? Who's the driver in this? Is it public, private?
Well, I think it goes in both directions. That if you were a Canopy, if you were a Southern Cross, if you were any of the private providers, I think making a joint approach with a proposal will always be well looked upon. The government may not be able to do all of them. Equally, I read Simeon Brown's speech at the Beehive from early on in his tenure, which I thought had an excellent structure. You can see that he wants to make greater use of the private sector, and I was fortunate to meet him on my last visit, and we talked about this. So this notion of developing a joint blueprint to better utilise health resources in Australia and in New Zealand means that you don't have spare beds in private and excess demand in public.
Yeah, I think he's made himself available to the FSC as well. We had a recent breakfast with him, a bunch of the health and life insurance CEOs. Really good to have someone listening, so hopefully we see some traction coming through there. In terms of funding horizons, Claudia, you mentioned it. What's the optimal, and how do we get that right in a short political turnaround time?
I think that's part of the challenge. So in a different capacity, I used to operate a big division of Auckland Council, so I'm quite familiar with complex governance structures. And as I was reflecting on what I can learn from that might be relevant to healthcare and this challenge that we're dealing with now, probably a good example is what's just happened to Auckland Transport. So I don't know if anyone here works for Auckland Transport. It might not feel so good for Auckland Transport right now, but what the intention of this change is that Auckland Transport was typically governed both by central government, got 50% funding from central government from Waka Kotahi, and then they got 50% funding from Auckland Council, and there's a whole bunch of user charges. And there was a real challenge in that the public lost confidence, rightly or wrongly, in Auckland Transport because of cones or roadworks or whatever it might be. And that loss of confidence drove a reassessment of a shared governance model. And it required a legislative change, but it pulled Auckland Transport back into the planning frameworks of Auckland Council, and it's now set up, by the looks of it, I'm no longer there, set up a structure where it's half ministry represented, half council represented. There's a different governance model. Now, I like the idea of thinking as an industry together, but we have ComCom rules that we need to be really careful of. And so even if industry does work together, it has to be done in a framework that we are not in breach of Commerce Commission rules, but equally that it's done not seen as a way of trying to line our own pockets from central government, because that's the part that they don't trust, understandably. So we need to think about that. Now, the challenge is all these things take time. So if we look at the capital investment program that hospitals need, that the public sector needs, if we look at the new technologies coming, which are enormous but take massive investment, millions of dollars, billions of dollars for some of it, we cannot do that on a 3-year horizon. We have to do that on a 10 to 20-year horizon, just like Singapore does with its airport planning, which is even 50 years. We need to think ahead. Now, how do we think ahead? We look at the demand projections of disease predictions, which exists, actuaries in the room would know it, you'd be absolutely expert in it. We look at the workforce supplies and technology trends that accompany that. We look at where the capacity is needed, and we work together to develop the capacity, be it funding capacity or supply capacity. But somehow at the moment we've got these very fragmented models and they're too short for us to really be able to forecast ahead. So if I'm a private provider, I do my own analysis on what is coming so that we can plan ahead. But I don't know what others are thinking, and therefore if we're just going to be going down the wrong pathway, or if we're going to be doing exactly the right thing by our communities. And it's that level of uncertainty that adds cost of capital, because there's a risk premium. So if we had longer horizons, we could understand and carry greater risk as a provider. We could sharpen our pencils. But if insurers had longer horizons and perhaps greater certainty of how risk pools can be managed, either through volumes or through other supports, maybe that reduces the insurance risk. Ultimately, everyone carries risk. So we need to find the things that reduce that risk so we can make healthcare affordable, and that we can make sure that that risk is somewhat carried fairly, because otherwise we see these tensions in the sector that don't serve anyone well.
We have some further challenges. We've got a fairly geographic dispersed population, some areas of high density, and then obviously with some more rural areas. And then on top of that, we've got a diverse ethnic makeup of population. Amy, how do we ensure that we are achieving an equitable outcome?
Yeah, New Zealand, I think, is one of the often cited countries where we know that inequities really play because of our geographical distribution, and we know from our health data that is available to us that access to medications, access to health services, waiting times, or time and time again, we know that we have disadvantaged populations, rural populations, our Māori Pacifica populations. They all have worse health outcomes and poorer access to timely treatments. And one of the things that I often think about is what are our purchasing models at the moment, and are they actually fit for need? And for example, if we just take pharmacy services, often we're paid based on a number of prescriptions, based on volume, but that's not an outcomes-based model. And outcomes-based purchasing is perhaps what we fundamentally should be moving towards. And one of the things that we could do to ensure equitable outcomes is that built into the outcomes-based purchasing should be lines and KPIs and metrics that measure equity. So in terms of outcome-based commissioning and purchasing, should we be thinking, are we responding to those communities of high need? What can we do to build in to reduce bias as well, and making sure access is equitable? And I know that for example, pharmac policies, they have just built in for some of the diabetes drugs around ensuring earlier access for high needs populations such as Māori and Pacifica. But simply also, it's really difficult to think about, are we just looking at ethnic based, and how do we actually measure that equity and access? So the other challenge that we have as a health system is metrics. So we talked about data, but we also need really good metrics to be able to actually assess, are we meeting the needs of our population? So I think metrics is another area that we can definitely respond better to. How do we measure success? How do we measure equity? How do we measure that we have met the deliverables that we set out to achieve? So those are some things I think that we could be thinking about in terms of increasing equitable access to healthcare services.
Great answer. Claudia, how does that fall into your space as a private provider?
So I have probably spent 20 years learning about outcomes-based funding. And I must say, I wish I wasn't so sceptical, but I'm sceptical. And it's not because I don't believe in the concept. It is just so hard to implement. So I spent 2 years with one of our funders trying to completely redesign the models of care for a certain type of injury. I've spent years trying to completely redesign other services to make it more affordable and efficient. And the concept of outcomes-based funding sounds really attractive. Where the rubber hits the road is the lack of data, but also that time frame. So people want outcomes for things that take longer than what they're willing to pay for. So if we look at the most successful model, so I'll pull out an example. I believe in Sweden, there's an outcomes-based funding model for total hip and total knee joint replacements, right? So that was great, but I think it's a 2 or 3 year horizon. And it showed apparently a 20% reduction in the cost of the episodic care for the surgery, right? What it did, though, is that it resulted in a potentially a better outcome, but it was done on a specific disease that is somewhat quite measurable, and the outcomes could be measured, but it also done over a longer time frame. And so the challenge I see is when we start getting traction on developing these outcomes-based models, which require enormous data, enormous analytics, and a lot of patient, and also really big investment by the private sector who deliver, we then face risks of contract changes. And if we see these pivots, it's very difficult to actually let something that takes a long time and is very complex to implement, it makes it difficult to do so. It makes it difficult for us to be able to go down that direction. Now, it doesn't mean we don't want to, but we haven't solved how to do that well yet. And again, I think it comes down to timeframes and data.
Yeah, I mean, I think that's clear as a fundamental challenge of getting a holistic view to inform a longer term view and funding model. Not as I think we started out with, we don't have the golden bullet answer. Greg, it looks like you want to contribute something.
Well, I mean, we have advantages and disadvantages in having a federated model with states. But it's a fact. It'll be there for the next 100 years, probably for the next 1,000 years. So it's a fact. It's no point worrying about it. In the health space, we allocate federal funding to states for hospitals on a 5-year rolling basis, and so those 5-year agreements are hard fought and there's lots of blustering. But one of the things we've been able to do is the majority of funding is a sort of a block funding, which includes activity-based, so for episodes of care. But a proportion of that funding is outcomes-based, with pluses or minuses for successes or failures. And so I don't think you can take away the base funding. I think Claudia is absolutely right on that. But I think you've got the capacity, which you could do through your health districts, and then they've got an increased role and independence under the current government, where part of that funding is related to very specific areas which are measurable in terms of outcomes. So many things are not measurable, and it would not be fair to look at a sort of an area with lower natural outcomes because of their population makeup or because of their urban versus rural background, but relative to movements and relative to expectations. The second thing is I might have a visitor's perspective which could allow you to work through the appropriate competition rules in New Zealand for having a public-private agreement with a strong view from the private sector. This could be a job for you, Alex, and for the Financial Services Council. It would be a natural lead partner with government, which doesn't have necessarily a conflict, to be able to lead and coordinate and develop that 10-year roadmap for better public-private cooperation and therefore reduced waiting lists and therefore better outcomes. So as a vehicle, having an intermediary such as yourselves lead that could be a really productive thing. And then between the two countries, one example of how we can cooperate is the idea, you have great clinical trials. We have great clinical trials, but scale matters, particularly for phase 2 and phase 3 clinical trials. So to become a single clinical trial zone, a single jurisdiction where there's mutual recognition for approvals, so with an Australasian one-stop shop for clinical trials, and the diversity which comes from the two populations together, will make it a more attractive destination for Merck and Pfizer and Novartis and AstraZeneca and other companies to be doing their trials in New Zealand and Australia.
I think you must be peeking at these questions because you've just answered one of those from Ian, which was how Australia and New Zealand can, if they can cooperate in defence, what are the roadblocks to getting the two countries cooperating in the private and public health space?
I mean, you could have a broader health partnership which looked at mutual recognition of health insurance. Certainly the clinical trials is an easy one. Health insurance is a bit more complex. And, the access to the public system is, for Australians in New Zealand and New Zealanders in Australia, is pretty well established. But perhaps a broader health agreement, health partnership agreement between the two countries is quite achievable.
Yeah. Here's one, I think, from probably for you, Amy. How much overall does medical research play in solving these problems? Should governments do more in this space to develop or discover better ways of treating ailments faster and or cheaper?
I think this segues nicely. I think Greg talked about clinical trials and set the platform for it. But I was just thinking and reflecting, we haven't really touched on probably one of the hot topics is around AI and digital technologies. And one of the biggest shake-ups in the clinical trial industry is around decentralised trials or remote healthcare. So no longer do our participants really need to go to study visits or be located in a participating site in one country. We are often increasingly seeing a move towards decentralised trials. So you have a central hub for coordinating these clinical trials. Your participants can come from anywhere around the country, be it in Australia or New Zealand, and this also helps with equity as well in terms of rural and urban representation and access points. And a lot of the remote monitoring could be done remotely in terms of health measurements and outcomes, and also, now with remote care since COVID, we can definitely career packages to people, treatments can be given closer to home. So that can definitely really revolutionize, I think, in terms of medical research and also clinical trials. In terms of medical research, we know often we lag in terms of uptake of new treatments. Often we see that New Zealand are often the last to uptake and it's often at the moment, about a 3 to 5 year lag when it comes to new pharmaceutical treatments. And which is why increasingly that pressure for health insurance to purchase and for private funders to go and get the newest treatments. But actually whether that is the best way to use that money really comes down to what Greg was saying. If there was an agreed partnership between the countries and between the public and private sector, then what we can do is really capitalise on that to try and bring those more expensive treatments and those gains from medical research into the country earlier and be able to increase some of that accessibility. So I think medical research can really drive both access points, but also is a source of revenue as well. So often New Zealand is discounted from those major global trials because it's seen that we don't have much representation or we don't have the capability, but we can have that agreement with Australia that will also build up some of our capabilities for clinical trial, which serves as a platform as well for attracting more revenue. And I've seen it come across my table. I sit on one of the Health National Ethics Committee that approves clinical trials, and New Zealand only ever gets like 2 or 3 patients in these major global trials. But actually, we could have much better representation if we draw on technologies and better partnerships across the Tasman as well. And so I think there are many gains that we can think about if we look at capitalising on those opportunities.
Yeah, I think you also touched on a good, I guess, generally good new development in terms of technology, AI, etc. Certainly with the reduction in latencies, we've seen wider usage of sort of transatlantic or transocean surgeries, etc. On a personal level, my sister, who's a radiologist living in South Africa, is actually a radiologist in New Zealand as well via teleradiology. So certainly that can help solve some of the supply constraints that we currently experience. Touching on AI again, peering over my shoulder here, perhaps for you, Claudia, to what extent is the New Zealand Pharmac system hamstrung by American pharmaceutical companies? And is there an opportunity with AI or otherwise to circumnavigate these companies and their high costs?
Oh, I love that question. Who's brave enough to put up their hand for who asked it?
I've got a name
well
here.
done. I've worked for both the big pharmas in the beginning of my career when I had to learn how to do a lot of complex financial analysis and to acquire biotechs. And then I worked for Pharmac, and then I worked on the provider side. And it's interesting because somewhere in the middle of all of this is the truth, right? So the big pharmas, they would say they do a lot of research, they do a lot of investment, and they take a lot of risks, and they should get money for it. Pharmac would say, hey, we have to control the funding, and we're given a very limited funding pool. So we have to eke out every single dollar through better contract negotiations so we can open up the pipeline for more drugs. Now, the challenge will be this. I've just come back from the States a few months ago. I was at a big cancer conference in Chicago called ASCO, and AI is amazingly and scarily transforming research. The amazing thing is that the number of compounds that will be created is going to be massive, beyond massive. We cannot keep up because what used to be a previous bench researcher, someone there trying to find novel drugs, these poor PhD students in terrible environments dealing with beakers, that will all be, and it already is being, completely modernised, robotised and AI'd. That means that there's going to be so much coming into the market, our regulators will not be able to keep up. FDA will not be able to keep up, MedSafe might not be able to keep up, and Pharmac or any other funders are going to struggle as well. And if we then look at the CDC funding changes of the current administration in the US, and if we look at how they've reduced the CDC funding for cancer, for other science, all the university-based sciences are going to really struggle to get developed. Now, where I see that could have an effect is that big pharmaceutical companies, biotechs, especially the very large ones with great AI models, will probably accelerate that. We'll no longer need universities as much. But that creates a workforce challenge in the future, but it also creates a continued regulatory challenge in the future. And someone needs to pay for this stuff. And it's either our government, our insurers, or our own pockets. And while I'd love to believe that these drugs are going to get cheaper, the pricing of drugs is determined by demand and supply. And if there's a high enough demand and there's a high enough desperation, that can really drive up the prices. And we've seen that with other case examples overseas. So we have got a very big challenge and opportunity ahead of us to try to figure this out. And it's going to need very good actuaries. So whoever's actuary in the room, I love actuaries, I'm a huge fan. We're going to need more of your amazing data expertise, and we're going to need that AI to come into your data expertise to accelerate it, because we're going to have to get across this data, the cost of these innovations, a lot faster.
So an opportunity which comes out of what Claudia says and two trends. The opportunity is, with the changes in US funding models, they will be looking for new homes and new sites, and many, many senior scientists and researchers are looking at Australia and New Zealand as destinations. And so to have a proper talent acquisition program, now is the moment, to be able to recruit. There is a huge opportunity to do that for both countries. Highly desirable destinations from people who feel that it's a sort of a culture within which they can easily fit. That's the first thing. Second thing is to take what Amy was saying and you think, what are the mega trends that are changing health in the world? And you can almost boil them down to two things. There are the tools of precision health, genomics, which is allowing carrier screening and children to be born without cystic fibrosis or Fragile X or spinal muscular atrophy, to do early stage targeted screening of individual tumours to determine the best individual therapy for people with the same notional type of cancer. Stem cells. And so we have a medicine like Zolgensma, which it's a $2 million medicine, but which allows for an effective lifetime treatment, not technically a cure, but a lifetime treatment for spinal muscular atrophy. And whether it's hips, knees, whether it's eyes, whether ultimately making progress on mitigating, halting, or recovering from aspects of dementia, albeit that might be a 2 to 3 decade process. Transformative. And then AI is about incredible efficiency in the back office of healthcare of this is how you connect public and private, and you connect data anonymised and consented. Then the patient interface, so the patient can call the avatar of the psychologist or psychiatrist at 3 in the middle of the night, in the dark of the night when they're having a crisis. And it's not diagnostic, but it's reflective, and there's a lot of work showing how real this is. And then there's the advanced research and, in radiology in particular, but in medical research, in pathology, the diagnostic work which can come from AI is transformative. And then all of that leads to this second big trend, which is the distribution of health services via telehealth and then remote diagnostics, whether it's the Apple Watch or the Whoop, which I saw Grant Simmons wearing before, or the Evie ring, the Movano ring, the continuous glucose monitor. Patients will progressively be treated in day hospitals, in low acuity facilities, and more hospital in the home and aged care in the home. And that's actually really important to reducing the cost per unit and increasing the health benefits for individuals. So those three precision medicine trends are then combining with the other technologies, the remote technologies, to dramatically change. So hospitals have to move from being 4 walls to integrated systems. Classic 4 walls, day, low acuity, and then ultimately more and more hospital in the home. And that's going to help the remote, rural, Indigenous, patients with low mobility, elderly, single parents, all of these things. So that's quite a transformation in how health will be delivered over the next decade.
And I think, so just to jump in quickly, so I absolutely agree with this and where it's going and the huge opportunities. One thing, therefore, you could think about, coming back to the outcomes-based funding, coming back to funding in general, currently the funding is done in silos. We're paid for an episode of care. We're paid to do imaging, and then we're paid to do cancer. And what we're not paid to do is to bundle those in an effective way. I'm not saying we wouldn't be effective or the insurance wouldn't be effective, but at the moment the way the bundling doesn't work doesn't allow for that level of transformation. Because we still have to work. We can still transform, but we still have to work in those silos. So if we're going to start thinking about this incredibly huge opportunities ahead of us on transforming healthcare, we should probably also start looking at how will we fund for that, and maybe just pick some key areas and give it a good go. Do a bunch of analytics together, bring in the right people, and figure out, how we're going to deal with cancer costs in the future for New Zealand, for example, with these new tools.
Yeah, I think we've got 2 minutes left, but I think it's clear that the message is we need to be taking a systematic approach to the entire ecosystem, and data is going to play a fundamental role in that. Amy, do you have a closing comment, given that the other two added their opinion on that?
Well, I think absolutely we said there is so many challenges ahead. I think the challenge that I pose to all of you having come in here is so easy coming to conferences and taking away, we've had the 2-day conference. I think the challenge to all of us is, can we move things along? He's like, exactly as Claudia said, can we take one challenge and one topic and try and see, can we apply innovation to it, whether it's establishing that shared framework that Greg suggested, can we work together, work with industry partners, talk to our government contacts and say, actually, we need a 10-year roadmap. What can we do to drive this change? I've just been to the FSC 2-day conference. These are my learnings. What can we do to take this forward? And then think about what tools do we have in our pocket? We look within our companies. Can we start applying some of those AI tools and actually start forward planning, you said, that 10-year cycle, that 20-year cycle, and really challenge ourselves to think, what is on the horizon and what can I do to actually make that step in the right direction to change healthcare for tomorrow? So I think that is the challenge for us all.
Awesome. Thanks very much. I think we're at time. I just want to thank the 3 panelists as well as the audience for the great questions that came through. Hopefully you've gained some new perspective.
Now, Alex, I just want to say thank you. It's been a genuine privilege. There's been a lot of agreement between us, but just so as you don't think it's all too scripted, you may have heard of the Wallabies. And you have a team called the All Blacks. I just want to put everybody on notice that we won one of the tests against the British Lions recently. We won one against South Africa, and we've just beaten Argentina. So next Bledisloe Cup, it's on.
I purposefully did not want to go into rugby. We'll leave
Nice one. Good luck.
Thanks, everyone.